Today, I want to welcome David Contorno. He is the founder and president of E-Powered Benefits, and he's been actively engaged in healthcare since his teenage years. And one of the things that we're going to be talking about today is how employers can reduce their number two or number three line item double digits. David's story is important to me because of my story, and many of you know that I learned some very expensive lessons in the hospital 3 years ago. And one of the things that David said is that he wants people to start asking different questions. And that aligns so much with, one of the things I published in my book was my two biggest mistakes of 2021 were that I didn't ask enough questions and I was asking the wrong questions, and it nearly cost me my life. And so I'm glad that that's part of David's mission. One of his goals is to give both control and savings to you and your employees. And one of the ways he does that is through transparency. So, David, welcome.
Thanks for having me, Greg.
Yeah. And again, I've talked to some of your colleagues that are doing the same things as you, and I think it's unknown to so many businesses out there. They just assume, hey, here's the deal. Healthcare costs are going up double digits. We need to figure out how to pay for that, or we have to start cutting back services to the employees. And the things that you are opening my mind to is no, that's a false choice.
Yeah, a lot of people say that our healthcare system is broken, and I disagree with that statement. It's not broken. It's working exactly as it was designed to work. It just isn't designed by employers, doctors, or patients. So it's not working very well for those three stakeholders, but it is working really well for a lot of people. I mean, look at how much these carrier execs make. Look at how much the hospital execs make, even the nonprofit hospitals. Just the other day, a CEO of Steward Health stepped down because the FTC had been suing them for claiming bankruptcy while he was doing all these lavish gifts to himself. And he finally got subpoenaed before Congress and then stepped down. And so, here's this hospital that's trimming down patient services, claiming close to bankruptcy while the CEO has a jet purchased for him and luxury homes and so on. So the system is working really well for a lot of people. And the reason asking different questions is so important is because you wind up getting different answers. And I think there's two massive misconceptions in healthcare and health insurance that employers need to fully understand. The first is that healthcare and health insurance are two separate things. I mean, if I ask most of America who provides their healthcare, they're going to say Blue Cross and Blue Shield, yet Blue Cross and Blue Shield provides zero care. Your doctor provides care. Your nurse provides care. So that's misconception number one. We understand cars and car insurance are different, but for some reason we intermingle healthcare and health insurance. The second thing is in what's known as the commercial market, which is where all employers of any size sit and where individuals who buy their insurance on the exchange, for example, sit. That's all the bucket called commercial insurance. And since the Affordable Care Act passed in 2010, there's a provision of that called the medical loss ratio provision, which says the carriers must spend 80 to 85 cents of every dollar they collect in their premiums on healthcare costs of the people on the plans. Well, this means they get to retain 15 or 20%. 15 or 20% of a bigger number is a bigger number. And so the only way for carriers to increase their profit is for premium to go up. And the only way for premium to go up are for claims to go up. And I wish these successful CFOs, they think the opposite is true. They think United Healthcare's profit goes up if they deny claims, if they negotiate better reimbursement rates. And that is true on the Medicare side of the house, which is what happens. Costs go down on the Medicare side. But on the commercial side, the incentive is for costs to go up. And so really the system we have, and Charlie Munger said this best, if you show me the incentives of any system, I'll show you the outcomes. Our incentives in our system are designed to give us the exact outcomes that we're getting.
Well, and let me give an example to that really surprised me in my own journey. There was a company that supplies oxygen, usually oxygen concentrators that are, portable and taken home with patients. They started billing me for portable oxygen when I was on the ventilator and in a coma. And this went on for 2 years. And it took me a while to discover it. There was one time where my wife, bills would come in, my wife would just pay the bills, and it seemed appropriate. We were on oxygen, then figured out I'd never been their customer. I was getting oxygen from someone else. I contacted them. They said, nope, you got the equipment. We're continuing to charge. I went back to them twice. Then I contacted Blue Cross Blue Shield, my carrier, and they actually found in the record, they're like, oh, yeah, I see. You're being billed for oxygen here and you're being billed for oxygen here. Let me look into that. They did nothing. And this company, which by the way is a bona fide scoundrel, they had to settle a case with the DOJ in 2018. They paid 10 million in fines and admitted that they were fraudulently billing people for equipment they never delivered. And Blue Cross Blue Shield didn't fix it.
Well, it was for them, it was fixed because what exactly happened benefits them. The only reason that they deny claims, there's two reasons why they quote deny claims or try to lower costs, or two circumstances under which they do it. The first is if their costs are inflating more rapidly than their competition, because then that filters down to premium, which prices them out of the market. So sometimes they put a little pressure down a little bit to not inflate faster than their competition. But the other reason, and the much more common reason, is what they're actually making very painful to do and get is what we call high value care. I'll give you an example. Primary care. The reason primary care is called primary care is because it is where you are supposed to go primarily, but we don't. We have a back pain, we go to a back surgeon. We have a skin rash, we go to a dermatologist. Things in which much more severe care is much more likely to occur at a much higher cost than if we could go to a primary care doctor and get to see him or her in a reasonable amount of time and see him or her for a reasonable amount of time. But the carriers have made primary care very miserable, intentionally, in my opinion, by lowering and lowering and lowering the reimbursement rates to primary care. By doing so, they made these primary care doctors have to see more and more patients every day, have to bill for more and more services. And even then, the rates went so low that these practices were still losing money. So a lot of people listening to this podcast, how many of you experienced where you go to your doctor one day and you're speaking to the owner of the practice, and then you go back for your physical a year later, and all of a sudden the local health system logo is on the door, and now he's a hospital-owned employee. Now, my question to you is, if these primary care practices are losing money, which most of them are, why are hospitals buying them up? Well, they're buying them up because they become the milk at the back of the store. They become the loss leader. They become the entryway into pushing them into more expensive services. And they pay doctors to do that. There's a little known publicly metric of doctors' pay called RVUs, or relative value units, which is a measurement of how much money they're helping generate in other parts of the healthcare system. So when they send you out for an expensive test, or even where a surgery is more likely to occur, they make more money. When that occurs, the carrier makes more money. When the rates go up because that occurred, the broker makes more money because most brokers are paid commission. So again, you have a lot of people benefiting from this really broken system, whereas we're big endorsers of a model of primary care called direct primary care. And these are doctors that charge a monthly membership fee. They never bill insurance, so their office overhead is way, way, way lower. Their patient panel size is 1/5 or 1/7 what a traditional doctor has. So you get in the same day, the next day. You never pay a copay. They never bill insurance. And now I have unlimited time with my direct primary care. And I go to her for everything. And it's only if she thinks that I truly do need, without her being paid to give me this advice, that I need a specialist, that I go. And so these primary care doctors are the most broadly trained doctors of any doctor in the medical space. And yet we've devalued them just like we've devalued pharmacists. I say all the time, pharmacists have been devalued to the point where all they do is take pills out of big bottles and put them into smaller bottles. They're doing nothing clinical. We've taken that all away from them, even though they have clinical training.
Yeah, and let's kind of pause there on the pharmacist, because there's something that I still don't think I fully understand, but it sounds like a money racket between the insurance carriers, the pharmacy benefit managers, and the pharmacist. And the pharmacist, if I understand, gets screwed.
Yeah. So there's another entity which is starting to become a little more talked about in the political and employer ether, known as a PBM, or a pharmacy benefit manager. And just like there are four big carriers, there are four big PBMs. You have Optum, which is owned by United Healthcare. Now, I say owned by United Healthcare, but really Optum does more revenue and more profit for United Healthcare than the insurance division does. So this entity, who largely just processes a transaction of a prescription, is making more money than the entire insurance company. Now, why is that? Well, they do the number one source of revenue for the big three. And the other two, by the way, are Express Scripts, which is owned by Cigna, and Caremark, which is owned by CVS, that also owns Aetna. So do you think it's any coincidence that these large carriers are owned by or own a PBM each? And even Elevance, which used to be called Anthem, Gail Boudreaux is the current CEO there. She used to be the CEO of United Healthcare, and she's one of the reasons Optum became such a driving force within the company financially. She's now at Elevance, and they didn't own a PBM. So they started a PBM, and within a few years, they had incentivized brokers to the point where that PBM was doing several $billion in revenue in a very short period of time. But the number one source of revenue for these PBMs is what's called spread pricing. And spread pricing is where whoever's footing the bill, now that might be the employee or the patient, because maybe they're in a high deductible health plan and they haven't reached their deductible, or maybe they have a copay, so they're paying $20 and the plan, their employer's plan that they also pay for, is paying the difference. Wherever it's, or they're covered 100% and the plan's paying 100% of the drug, wherever it comes from doesn't matter. What does matter is that these PBMs are charging a higher price to whomever is paying for it than they're paying the pharmacy. So not only are these employers and patients incurring administrative fees for that PBM to process the transaction, which is, they do provide some process within this, but on top of that, they're inflating the cost of the drug to where the drug is, I mean, we've seen drugs marked up 4 or 5 or 600%. Like, we're not talking 2% or 5% or 10%. And so now their rates are going up faster as a result. Their out-of-pockets are going up faster as a result. And we know the number one reason Americans don't adhere to their medication is because of affordability. And that's no different with those with insurance than without.
So the thing that confuses me is, why do we need a pharmacy benefit manager? If a doctor prescribes me a drug and it's covered by my insurance, why can't I just go to, for me, it's HEB, the grocery store, big Texas grocery store, and I get my drugs? Why do I need a middleman?
Well, you don't. But the reason they were put in place, I think, was, again, there was good intention, but it sort of got perverted over time. But initially, they were put in place to, number one, aggregate many employers into a single bucket to increase purchasing power against the drug companies to pay lower pricing for the drugs. That was one of the initial promises. And the other was to be a second check, both from a clinical perspective and a financial perspective, to ensure, hey, wait a second, is this person filling drugs somewhere else that might have a contraindication with the drug they're about to fill? Are they abusing opioids? And how do we get a more holistic picture? And then also from a financial perspective, did they try these lesser expensive treatments first? Because no generic drug manufacturer are courting doctors. The only ones that are courting doctors are the brand name and the specialty medication manufacturers. And so they get told that this is the newest, greatest, best thing, when clinically that may not be the case. And so the other purpose of the PBM would say, whoa, 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 before you try this $10,000 a month drug, let's try this $20 a month drug first. But again, because of how they're paid, those rules got perverted to benefit the PBM. And here's the thing about PBMs. They don't have to follow the medical loss ratio provision. So they can generate much, much more than 15 or 20% margins on the drugs they fill than the carrier's side of the house can make on the drugs they pay for and the care they pay for.
So it's basically a financial shell game when the carrier has been limited to 15% of revenue. They just move the profits over to the PBM.
And I believe, and I don't have any proof of this, but man, all my years, 30 plus years of doing this, tell me I'm right. So this medical loss ratio provision, they have to run at 80 or 85%. And the delta, by the way, is the size of the groups. If you're over 100 employees, it's 85-15. If you're under 100, it's 80-20. But here's the thing. If they run under that, so if they spend less than they anticipated, they have to give the difference back to employers, who then have to filter it back to employees. When this first passed, the first couple of years, some of my employers would get these token checks that weren't even worth distributing, but I don't see that happening or hear that happening now. And if they go over the 80 or 85%, that's on them financially, and that's a loss for them. How is it that these carriers are insuring millions and millions of people with highly unpredictable healthcare needs and healthcare costs, but yet every year they come in right at 80 or right at 85%? It doesn't seem possible to predict it with that level of exactness when you have to do it 18, 20, 24 months in advance. It doesn't seem possible. And so I really believe that they're playing with that spread pricing up and down, where they have practically unfettered ability to mark up or mark down medications to make sure that they come right in at the 80, 85%. I'm sure there's other levers, but I think that's one of the major ones, and one that's very easy for them to pull.
Well, as I'm hearing all this, I mean, I'm just getting anxious listening to it because it leaves me with a sense of hopelessness. And and I guess the question is, for employers that are seeing these, the employee healthcare costs skyrocket, do they need to feel hopeless?
They do not. And what I'm about to tell you that we've been doing for 14 or 15 years. And thank goodness we're not the only ones anymore. There are consultants around the country. But what you need to do as an employer, and then we'll talk about a patient separately, but what you need to do as an employer is you need to make sure that every entity within your health plan, and there's really 6 primary entities. Within the plan itself, you have plan administration, you have a way to reprice the claims or to price the care, you have the pharmacy piece, you have medical management that's supposed to determine what's medically appropriate and what's not, and what follows the plan documents and what doesn't. And then you have some sort of risk mitigation for large claims. And these 5 components exist within every health plan. Even if you're fully insured with Aetna, they're all owned by Aetna in that case, but those are the 5 main components of the plan. And I said 6 because the 6th one is where you're getting your advice on which one of those 5 to do. And what you need to do is similar on all 6. You need to understand how they get paid, each entity within there. And you need to make sure that at the very least, they don't make more money by costs going up. Ideally, they make more money as costs go down, which is how we're paid by our clients. The more we lower costs for the employer, the more they pay us, typically a small piece of the savings. And it's amazing how when you turn the financial incentives around, you get different results. You get the results that the incentives are meant to induce. I get really frustrated by doctors and brokers in particular, traditional doctors and traditional brokers, claiming they're not influenced by the commission, bonus, RVU, patient volume game that determines their paycheck, when they keep on delivering in aggregate the exact results that those incentives are meant to deliver. So from an employer perspective, you need to really listen. You may think you're in the widget making business, but when healthcare is your second or third biggest spend, I'd argue you're in the healthcare business first and the widget making business second. But you understand how to make widgets a heck of a lot better than you understand your healthcare and health insurance. And so break those 5 components apart, 6 with the broker, and say, where do you make money? How do you make money? That's not acceptable to me. I mean, if fire departments only got paid when there were fires, and the bigger the fire there was, the more money they made in their budget, we wouldn't have sprinklers in commercial buildings. We wouldn't have fire hydrants every block or 2. The financial incentive would be to fires to incur, but instead the fire departments get a fixed budget, which is, by the way, how Medicare works. And the less fires there are, the more money they retain. You need to get into a situation where when the right care is doled out at the right time, at the right place, at the right price, that is highly incentivized, rewarded, or mandated. And let me give you guys some difference here to understand. We have found, and we have quality metrics of almost every doctor and almost every hospital across the country. And when we go, let's say, to an orthopedic surgeon in an area for orthopedic surgery, and we look at all the surgeons in that area, and we sort them by highest price on the left to lowest price on the right, we're also sorting them by lowest quality on the left to highest quality on the right. In other words, there's an inverse relationship between cost and quality in healthcare. And that inverse relationship not only drives outcomes, but has a massive difference on the cost of care. And so what we do is we either directly contract with providers. We have tens of thousands that we're directly contracted with, and they love direct contracts because providers hate dealing with insurance companies too. So within our direct contracts, we make it better for the hospital and or the doctor by, number one, not having to deal with filing a claim. Number two, they get paid in full. They don't have to worry about collecting or usually not collecting from the patient because of their deductible and they're out of pocket. So we're able to identify these high quality providers. We're able to incentivize members to go there by saying, hey, if you go to this doctor, here's the reason why he or she is better, lower infection rates, lower mortality rates, lower readmission rates, whatever. And if you go there, and we don't say this part to the patient, but if they do go there, the cost is so much less that the plan, their employer's health plan that we helped create for them, is going to pay 100% of the cost. So now they're getting better outcomes. And in the case of orthopedic surgery, I mean, a bad orthopedic surgery can keep you out of work for weeks or months even. So having a good orthopedic surgery with a shortened recovery time with less complications means that employees back to work quicker. Or if it's a family member, they're back taking care of the kids quicker so the employee can get back to work quicker. They're also doing it where they're not paying anything. So their employer's health plan looks like a hero, and the employer's health plan is paying a lot less than it would have had it shared in the cost and gone to a different place or a more traditional place to do it. So there's this win-win-win trifecta that can occur, but the carriers don't let you do it because it doesn't benefit them.
So one of the numbers that you threw at me, you said that you've been saving employers up to 50%.
Yep.
And, if I put myself in their shoes, I'm sitting here listening, I'm like, I'm missing something. There's a hitch here. I just need to figure out what the hitch is, and I'll figure out how I'm screwed by this other method. What are they missing?
First of all, the statistics are that 22 cents of every dollar that is spent on healthcare actually goes to healthcare. So I would argue if I were better at my job, I should be saving employers 78%, not just 50%. But if you want to really understand how this works, then what I recommend people do, and I know not everyone can do this or will do this, present yourself as a cash pay patient, even for something major, because the cash pay price is remarkably lower than the insurance price. I am a cash pay patient. I'm a 30 plus year health insurance salesperson veteran who hasn't had health insurance on my family for 6 or 7 years because I don't believe in traditional health insurance. It doesn't serve a purpose. As a matter of fact, it harms people. So think about this for a second. If you go speak to a hospital CFO and you say, what are your 5 main sources of revenue? They're going to list them out. You have commercial insurance, which we described before. You have Medicare, Medicaid, cash pay, and charity care, which they have to do, especially if they're nonprofit. And if you ask that CFO which one of those 5 brings you the highest rates for your services, they're going to say commercial insurance. In other words, when you throw down your Blue Cross and Blue Shield ID card, you are at that point contractually preordaining the health plan and the patient, usually a combination of the two, to paying the highest price in healthcare that hospitals receive. So if insurance is forcing us to pay the highest price possible, and I don't mean just in the US, but we have the distinction of it being the highest price for healthcare in the entire world ever, what's going to happen to your insurance? So when you get all that stuff out of the way, and we build health plans that don't do that 100%, but they work a lot better, saving 50% is not hard and doesn't take very long. Usually we're doing 35 to 50% at the end of the first year. Now, this doesn't come at people not getting care. Quite the opposite. We are getting them medications and imaging and primary care and surgeries with nothing out of their pocket. We're just going to the right providers who are high quality. We can demonstrate that with data and are willing to give a fair upfront price. It's really that simple.
I had that experience a couple years ago, I'm trying to remember exactly when, but I was talking to Near about it, we live, just a few miles from each other. And I have a condition where I get these little bumps on my eyelids called chalazions. And they're real easy. When you see them, you know what they are. They're real easy to deal with. You just land some and drain them and what have you. So I called 3 different ophthalmologists, and they all wanted me to come in for multiple visits. I'm like, look, this, when you see it, you're going to know what it is. You're going to know what to do. The first one wanted to charge me $350, and they wouldn't break it into two different visits. So I called the second one. I got the craziest runaround with them, never got a direct price, but stitching the dots together, I think it was going to be about $800. And the thing that I figured out with them was like, oh, they've built an insurance money extraction machine. That's how they've structured their practice, is to get more insurance money. And then I called this third one. I was telling Near about this. I said, they quoted me, it was like $240, I think. It included a half hour with the nurse, 45 minutes with the surgeon, and a follow-up appointment with the surgeon for $240. And he said, oh, I know the one you're talking about. They're independent.
Hmm.
And it was great care.
Yep. Yeah, we're the only country in the world in which the more healthcare that's provided, the more money the system makes. Every other healthcare system works opposite. They have a finite set of resources, and the less they spend. And that's why, even though we spend more on healthcare per capita and per country, I mean, if our healthcare system were on its own as its own economy, it would be the third largest economy in the world, just our healthcare system. And it is strictly based on us being sick. If we all got healthy, if I could wave a magic wand and all of a sudden we stopped going to the doctors and hospitals, or maybe we cut it by 75%, much like the airline industry was brought to its knees when people stopped flying, it also would do the same thing to our health care system. It would literally be brought to its knees within days if we got healthy. And so this manifests itself in many ways, but one way is I don't know of a single drug manufacturer of cancer drugs that's researching cures for cancer. They research treatments for cancer, not cures. So if you look at the incentives of the system, you will know that we're getting the exact results that they were intended to give.
So as we're wrapping up, we speak to leaders, usually business owners, as the audience. And my fear is that they're walking away feeling a little bit overwhelmed.
Mm-hmm.
What are a few, 2 or 3 simple things that a business owner should do right away after listening to this episode that will change their outcome?
The first is, there was a couple of bills passed over the last few years, the Consolidated Appropriations Act, abbreviated the CAA, and the No Surprises Act, abbreviated NSA. And there is a few things in those two things that employers are just not demanding they get. Number one is a broker compensation disclosure of anything, I think, over $25. If it's a meal, if it's golf, that has to be disclosed. And it happens all the time, all the way up to several 6-figure checks, oftentimes being written by the carriers to the brokers. So the first is get that disclosure from your broker if you're not already getting it. And I've not found one who's getting it without demanding it. The second thing is get your data. Now, carriers have long held data over where your money's being spent close to the vest, and they cried HIPAA didn't let them do that. Well, that's not true. HIPAA doesn't say who can have this data and who can't. What it does say is if certain entities have certain data, they must protect it in certain ways. Well, employers already have this data. In other words, they have information that needs to be protected under HIPAA, even if they don't have health information. So they already have to have these protocols in place, or should. So ask for your claims data in a full detailed dump and get that to someone who can analyze it and show it to you and say, this is where your money's going. Once you see that, and once you are shown the alternative ways to spend money on healthcare, you will not stand for the same results that you've been getting. And just imagine from an attraction and retention perspective, if I am able to reduce an employer's healthcare costs by 50%, that means most employers could pay 100% of that, nothing out of the employee's paycheck, and still be paying less than the employer is spending today. And when I'm able to deliver on the promise of a plan that provides for care and medication with nothing out of the employee's pocket, how easy is it going to be for you to attract and retain employees when you say nothing comes out of your paycheck and often nothing comes out of your pocket when you consume healthcare under our health plan? And family businesses love that.
Yeah. Wow. So how can people reach you to learn more?
I mean, certainly Googling my name, David Contorno. I'm pretty active on LinkedIn is the most social media that where I'm active the most. We have our own podcast, but if you are an employer, you can reach out to me directly, or we have a co-consulting program. So if you're a broker or consultant, or you're an employer that has a strong allegiance to your current broker or consultant, we partner with brokers and consultants around the country and teach them how to build these types of plans for their clients. So we just want these solutions out there in as many hands of employers, employees, family members, and brokers, consultants as possible. How that happens, don't really care, but either reach out or have your current broker or consultant reach out. But remember, if you're going to involve your current broker or consultant, this may seem even more impossible to them than it does to you, because they've lived in this system for a long time. And when I did, everywhere I went, I got the same answers. And so they may still very well be in that world. I had to really step outside and burn a lot of relationships with the carrier people that I had become friends with in order to fully move into this model. And it's really hard to live in both the traditional world and this, whatever you want to call this world to be.
All right. Well, David Contorno with E-Powered Benefits. Thanks for being on Leaders and Legacies.
Thank you so much.